Hello and welcome to Karen's Medical Corner. I'm Karen O'Day. I'm a certified family nurse practitioner and a certified nurse midwife in Santa Fe, New Mexico. I own Evercare Family Practice and my specialty is in family health care, women's health, aesthetics, and hormone replacement therapy. I appreciate you joining our podcast. Today I would like to continue our women's health series and discuss perimenopause, menopause, and treatment options. I'm particularly going to focus today on the treatment option of bioidentical hormone replacement therapy, specifically BioT hormone pelleting, but we will discuss the other types of hormone replacement as well. So first, I'd like to give a little bit of a definition on what is perimenopause and menopause. So perimenopause is the period of time leading up to a woman going through menopause and stopping her periods completely. So perimenopause usually starts around the age of 40 to 44, although it varies completely individual to individual. Some people will go through perimenopause or start to have symptoms much later and some much earlier. However, the average age is 40 to 44, and during that time, that's usually when the periods start to become irregular, either shorter in duration or longer in duration, shorter in the amount of time between the menstrual cycle or longer in periods of time. Sometimes women will start to develop sleep problems during that time, decreases in libido, change in their cholesterol, specifically meaning that the cholesterol will start to elevate, changes in their energy level, and changes in their overall activity pattern. It's during this period of time that some women will start to develop hot flashes and night sweats as well, and that can last for anywhere from a few months up to 10 years. Now, the definition of menopause is when a woman's menstrual cycle stops due to lack of production of hormones and they do not have a menstrual cycle for 12 months. So a woman is not considered to be through menopause or postmenopausal until she has not had a menstrual cycle for 12 months. So once she has gone through menopause, a lot of times these symptoms of perimenopause will continue. Some will start to improve. Some symptoms get worse. So I always ask women when they come in, what are your symptoms of menopause? And a lot of times they'll tell me that they are having hot flashes or they're having night sweats. They may be having problems sleeping, meaning they have an increased problem in falling asleep at night, staying asleep at night, waking frequently, or all three. Changes in mood is also really common. Women tend to become increasingly irritable. Sometimes they'll start to develop depression or increase in anxiety. They may start to develop increase in headaches or migraine headaches that they really haven't had in the past. They may have hair loss or changes in the texture of the hair, as well as changes in the texture of the skin. Sometimes women may feel cold all the time, or they may even feel increase in heat production, and especially in their feet and in their hands. A lot of women will experience what they consider to be an unnatural weight gain, where they're following a specific dietary regimen or they have not changed their exercise habits, but they are starting to gain more weight. And you'll notice a lot of times when a woman goes through menopause that their skin has a difference in its texture and increase in wrinkles once she's been a year without a menstrual cycle. And that a lot of the time is due to decrease in estrogen levels. Other symptoms that women have include increase in feeling exhausted or fatigue, not being able to do the activities that they used to do without any difficulties. And of course, common symptoms include vaginal dryness, increase in bladder infections, urinary frequency, urinary urgency, urinary incontinence, and also decrease in ability to have an orgasm, decrease in sexual desire as well. Other symptoms that women come in with are increase in memory changes, so kind of an increase in memory fog. They're not able to learn or retain information like they were before. They tend to have increased symptoms of muscle changes, so they're not able to build muscle as much. They notice a bit of muscle loss and increase in fat where they didn't have issues before. and sometimes increase in muscle complaints in general, muscle aching, muscle weakness, joint pain, that oftentimes is associated with decrease in hormone levels. So the first thing we do at the office is we take a thorough history. When did they start their menstrual cycle? How long has it been regular, or has it always been irregular? When did they start noticing these symptoms? And when they started noticing these symptoms starting to get worse to where they were affecting their activities of daily living. At that point, it's simple to tell what's going on with females in regard to menopause. It's as easy as a simple blood draw. Now, there is a little bit of controversy as far as doing a blood draw versus a urine sample versus saliva testing. But for the purposes of what we do in clinic, we know that when we draw someone's blood, we're getting that blood level at a moment in time. But that's the same with almost every single type of test. Nothing is specific 100% going to give us what's going on unless we're doing a 24-hour urine catch on somebody, and most of the time we don't need that to appropriately treat women. So when someone comes into the office and they need their symptoms treated and they don't want to spend a lot of money, because sometimes these tests are not going to be covered by the insurance company, we can do an easy test with a simple blood draw that includes the total testosterone level, the total estradiol level, progesterone level, and follicle stimulating hormone level. And depending on the woman's symptoms and if she's recently seen her primary care provider, we'll also check thyroid levels. That would include a thyroid stimulating hormone, a free T3, a total T3, a free T4, a total T4, and a thyroid peroxidase autoantibody to check for Hashimoto's thyroiditis. We'll also oftentimes check a complete metabolic panel as well as a complete blood count. And so those would be the basic testing. But if a woman has already had those done and she's coming to the office strictly for hormone replacement therapy, then we just do the hormone levels. Depending on what lab we use, we can have the levels back within 24 hours, which is oftentimes nice because a lot of times women don't come to the office until they're actively suffering significant symptoms and they want to start a treatment regimen as soon as possible. So those are the symptoms and the testing options that we can do. Once we do the testing options, we also discuss with the woman her past medical history. Does she have a history of endometriosis, of uterine fibroids, of fibrocystic breast disease, of any types of cancer, uterine cancer, breast cancer? What's her family history? And those are all important things to know about before starting anyone on hormone replacement therapy. Also, getting what allergies they have to medications or medication sensitivities is also very important. But a past medical history is very important prior to treating somebody for hormone replacement therapy. Has the woman ever had to have a uterine ablation? Has she had recently an ultrasound of the uterus, and if so, why? Has she had an abnormal mammogram in the pap or in the past, or an abnormal pap? And when was the last pap smear? It is recommended, for women who are in the perimenopause or menopausal age, under the age of 65, if they have normal paps, that they should have one every 5 years. And over the age of 40, it's up for debate in certain areas and certain medical groups whether they need a mammogram every year or every 2 years past the age of 40, but certainly past the age of 50 it's recommended for every year. I am very patient oriented as far as pro-patient choice. So if a woman does not desire to have a mammogram or a pap smear, we are not going to require that unless they've had significant abnormalities in the past, and then we would discuss that in detail and on alternative testing options, obviously. So once we have those questions out of the way, it's also important to get an idea of what their current medications are. Because depending on what medications they happen to be on, these may be medications that they've been given due to perimenopausal symptoms that actually have nothing to do with what they're being, treated for. What I mean is a lot of women will go in and they'll be having depressive symptoms, or they'll be having hot flashes, and a provider will put them on an antidepressant, when in fact, if their hormones were checked and were balanced, they might not need these antidepressant medications, which also have other significant side effects. So if a woman comes in with decreased libido and she's having hot flashes, putting her on a medication for an antidepressant may just further reduce her libido and her ability to have an orgasm, which kind of defeats the purpose for what she's coming in for. So I like to get a clear idea of what medications people are on, what their past medical problems have been. Do they have migraine headaches? Have they had history of depression, anxiety, bipolar? What are some of their mental health issues that they've had in the past, if any? And what's their cholesterol? Have they had difficulties with cholesterol? If they haven't had their cholesterol checked, I usually will add that to the blood panel, because we do know that as women age, their cholesterol, as their hormones drop, naturally goes up. And we can sometimes help bring that cholesterol down with natural hormone replacement therapy. So once the blood is drawn and they come back to the office for evaluation, we also take a thorough history on what their past surgeries are. Have they had a hysterectomy in the past? Have they had a uterine ablation in the past? Have they been treated for polycystic ovarian syndrome? Do they have their ovaries? How old were they when they started going through menopause? Because some women will tell me they started menopause in their 30s. And so that kind of gives me an idea of how they need to be treated. And so when they come back for follow-up, then we start talking about treatment options. Now, I'm not a fan of synthetic hormones. I think they're dangerous, and I think that there are much better alternatives. Now, we do know that bioidentical hormone pelleting has been around since the 1930s, and bioidentical hormone replacement therapy in other forms has also been available, but this has not been readily made available to the public due to Big Pharma being able to keep the natural hormone replacement therapies out of the limelight. Obviously, we know that Big Pharma is a huge industry globally. They are making billions, trillions of dollars selling their products. And all of these products have side effects and detrimental effects. So one of the issues that I run into when women come back to discuss their lab results is that almost 100% of the women that I talk to have been told horror stories about hormone replacement therapy. Well, a lot of this started with the Women's Initiative trial in the late 1980s, which ended in the early 2000s due to complications related to the synthetic hormones. It scared the entire medical field and totally turned off most providers from providing hormone replacement therapy to women. In fact, when this trial stopped due to increased risk of breast cancer, women were yanked off their hormone replacement therapy with no other options and had significant side effects and really had a decrease in their quality of life. But this trial, although flawed with multiple problems, has stayed the mainstay of research therapy for treating women for hormone replacement, which is really a shame because it never made sense. Several things. One, it never made sense to me that you're going to put pregnant horse urine into somebody's body. And two, just treating people with synthetic hormones in general never seemed like a good idea when we have bioidenticals available, but there never is enough education to women regarding the availability of alternative treatment options. Everybody goes straight for Big Pharma when they're treating, or it seems like it, not everyone, but a lot of people do. And even as a young nurse practitioner and a young nurse midwife, when I was in school, they taught us about treating women with these synthetic hormones. And when I was in school, this was when this Women's Initiative trial was really ramping up. And in fact, my mother was going through menopause at the time, and she was placed on Prempro, which was Premarin and Provera, a combination drug. And man, was it a life changer, not only for her, but for me and my dad as well, because she turned back into her old self. I mean, she had turned into somebody where we were either blasting the refrigerated air or blasting the heat. So either way, my dad and I were either freezing or we were sweating. She was grouchy all the time, crying for no reason. It was just like she had had this horrible change in her personality when she started to go through menopause, and it was really awful, and she was really suffering. So when she started taking Prempro, and she was not part of the study, it was just when this trial came out and they started seeing all these benefits for decreased risk of heart disease for women, everybody was placed on Prempro. And so when I was in school, Prempro was the go-to. It's a once-a-day pill. It was fantastic. And then all of a sudden, they stopped the trial due to increased risk of breast cancer and blood clots, and people started being pulled off of that medication very quickly. My mom was not taken off of the medication because she didn't want to come off of the medication, but then she did develop a blood clot, and she was taken off of her hormones and told, you can never take hormones again. And that was really a game changer for her. She went on antidepressants for a while. She was not feeling well, and she didn't think she could ever take hormone replacement therapy once she had that blood clot. Well, as it turns out, in my family, and myself included, we have a blood clotting disorder called factor V Leiden, where we have a genetic disorder that predisposes us to blood clots. And so for a long time, I also thought I could never take hormone replacement therapy because of my increased risk of blood clotting. And that also scared me as well, because I kept thinking this whole time, what's going to happen? Am I going to turn into my mother when I start to go through menopause? Well, then as my career continued, I started learning more about bioidentical hormone replacement therapy. I had some of the pharmacies from Albuquerque come and talk to me about the compounding they did for bioidentical creams, bioidentical liquids that go under the tongue, bioidentical troches that you can dissolve in the mouth. And I thought, man, that's something that is a good idea, but can I still use those? I don't know. Possibly not. And then I was introduced to bioidentical pellet therapy, which is also plant derived. So the pellets are little cylinders. I specifically use BioT pellets. I like those pellets because there's a number of different milligram treatment options, so it can be individually formulated for a specific female. There's not just 3 doses. There's not just 1 dose. There's hundreds of different ways you can formulate different pelleting dosages for the individual woman. And I started learning more about the pellets, and then I started looking up which pellets I thought would be the best, and that's when I actually contacted BioT and said I would like to learn more about your treatment for menopause and perimenopausal women, and as well as men. We're going to stick to females in this talk. And so they came out. They were very informative. They gave me the information that I needed, and that's when I decided that I wanted to become a BioT provider, which I currently am. And BioT hormone replacement therapy is probably the biggest type of hormone replacement that we do in the office, although I do use other forms of bioidentical hormone replacement depending on what the individual would like to try. So I currently get bioidentical hormone replacement therapy with BioT, and so does my mother. And we both have a blood clotting disorder, and neither one of us have had a blood clot. And it makes sense to me. It never made sense to me. Why would my mom get a blood clot postmenopausal from estrogen and progesterone and not have blood clots running through her system the entire time she was in her 20s and 30s when her hormones were the highest? Well, it wasn't the hormones that were causing the problem. It was the synthetics that were causing the problem, causing the issue. And that's what the problem is with the increased risks that we see associated with synthetic hormone replacement, and we do not see those with bioidentical hormones. And when I was a young nurse, it also never made sense to me when they were saying how dangerous hormone replacement was, because I always thought, well, if that's the case, I'm in my early 20s, how come I don't have breast cancer? How come I'm not having all these healthcare issues? And none of it made sense. Well, it's because it's the synthetics. But the Big Pharma doesn't want you to know that. What they want is for you to use their hormones until you have a problem, and then you're just taken off of hormones for the rest of your life. So bioidentical has been a game changer. It's been a game changer for me, which is why I'm such an advocate for hormone replacement therapy, because it really gave me my life back. I always thought when I was going through menopause, or prior to when I was perimenopausal and only having a few symptoms, I thought, oh, I'm going to be one of the 10% that just really doesn't have symptoms. I'm going to just breeze through menopause. It's going to be amazing. I'm just a tough cookie and it's not going to bother me. Well, no, that's not at all what happened. The first time you have a hot flash, that feeling of internal spontaneous combustion is absolutely awful. It is the worst sensation that you'll ever feel. And if you get upset about it, it gets worse. And so over time, I was trying to figure out how to make the hot flashes stop. And in fact, one time I was at Village Inn, which is a restaurant in Albuquerque with my family, and I was having this hot flash, and I'd been having hot flashes for a while. And I said to everybody at the table, I said, everybody stop eating, and I want you to just look at me right now. Look at me. And so everybody stops, and they're looking at me, and Amanda's like, are you okay, Mom? And I was like, yeah, no, I'm fine. I said, what do you see? And my mom and dad and my son and my daughter, and my husband, they said, nothing. What's going on? And my daughter says, well, I don't know, Mom. I see a little bead of sweat on your head. And I said, I'm having a hot flash, and I want to know what patients are seeing when I'm talking to them, and I'm having a hot flash. And so because I felt like I was turning beet red, like my entire body was going to explode with heat, and to find out that everything looked pretty normal, I thought, okay, well, that's better. At least I can kind of hide the hot flashes. But then the fatigue started setting in, and I would literally ride in the back seat of our truck, laying down and sleeping on the way to work, on the way home to work, because I just didn't have enough energy to do anything other than barely make it through the day. I could sleep 17 hours, and I would still probably feel like I needed more sleep. Complete decrease in libido. I was starting to feel like I was having vaginal pain just due to dryness. And I started to notice that my skin was becoming really dry, and that overall I just didn't feel good. And I started to become concerned because starting in my mid-30s, I started having trouble with osteopenia, which is bone thinning, and I was having a hard time correcting it with the FDA-approved medications. And so finally I gave in, and I talked to one of my friends who's a provider, and he said, Karen, why aren't you doing pellets? And I said, well, because I have this blood clotting disorder and I'm a little worried. And he's all, it's not going to be an effect with the pellets because the pellets are not absorbed in such a way that it's going to increase your risk for blood clots. And so I said, okay, pellet me. And oh my gosh, what a game changer. I will tell you right now, I will die with pellets in me. I am never going back to feeling the way I felt before. I started thinking about my grandmother, and she was postmenopausal since I can remember. And she slept 4 hours at night, and she was always grouchy, and she never felt good. And she always had these joint aches and pains and these muscle aches and pains. And she just looked and felt like she was old. And I don't want to feel like that. I want to feel healthy. If I'm going to live past 45, I want to feel good for as long as possible. I don't want to be 50, 60 years old and not want to do anything and just feel like crap all the time. And so after my first pelleting, and I got pelleted really soon after starting symptoms of menopause, but I started feeling like I felt when I was in my 30s. It was amazing. And it was at that point that I really started to become an advocate for hormone replacement because I never really realized how bad women feel. Nobody can describe how awful it feels for so many women to go through menopause. And it is true that about 10% of women don't have symptoms when they go through menopause. And I think that's fantastic for them. Unfortunately, the other 90% are suffering. And so if there's something that I can do to help this situation, and it really helped me, then I'm definitely going to do that. So with this simple blood draw, we can determine what somebody needs for hormone replacement therapy. And we can replace that with either bioidentical creams, which are used twice a day. They do have a half-life, so the downfall to using the creams is one, you have to put them on twice a day, so you're getting kind of this roller coaster effect where your levels go up as soon as you put the cream on, then throughout the day they go back down, you put the cream on again, and they come back up. That's the same with the troches, which are dissolvable tablets that go in the buccal mucosa. It's the same with the sublingual drops. It's the same with even oral bioidentical pills that you can take because there's a half-life. With the pellets, and the reason I decided to use the pellets, one was because of my blood clotting disorder, but two was because there is no half-life. The pellets are absorbed like they should be naturally based on your cardiac output. So when I'm sitting here doing this podcast, I don't have a huge use of my pellets. I mean, my heart is obviously beating because I'm on the right side of the grass, but my heart is not pounding. So I'm not using the hormones very much. When I go upstairs and I work out, then I'm burning my hormones just like I would when I was younger. But when I was younger, I was replenishing my hormones naturally. Well, now I replenish them due to the bioidentical hormones that I'm using. Now, unfortunately, we can't pellet progesterone. We can pellet estradiol and we can pellet testosterone, but they found through research that progesterone just does not absorb very well in the subcutaneous tissue. So what I like to prescribe is either a bioidentical troche that people can dissolve in the mouth, or a bioidentical progesterone, and there is one that is paid for by the insurance that you can write a prescription for. It's called micronized progesterone. That's personally what I take, and I take that because I have a uterus. So anybody who has a uterus has to take progesterone. You cannot take estradiol by itself, and if you are taking estradiol by itself and you have a uterus, you need to not be doing that. It increases your risk for endometrial cancer. It causes an overgrowth of the endometrial tissue, which can be very dangerous. So anyone who's on what's called unopposed estrogen needs to contact their provider immediately and get on to a natural micronized progesterone. So I take mine around bedtime because progesterone helps you sleep. And I wasn't sleeping at night. I was sleeping 4 hours at night and I was exhausted. So the testosterone has helped me sleep. And the progesterone has also helped me sleep. But the overall changes in life, so everything I've talked about with the memory fog, by balancing my estradiol and my testosterone, that has resolved. I don't have the hard time retaining information that I'm reading that I used to have problems with before. I'm retaining information much easier. My irritability is substantially better, which I'm sure that my family is grateful for, because my estrogen levels and testosterone levels have significantly improved. I don't have hot flashes or night sweats anymore. I don't have any migraine headaches. I mean, occasionally I'll get a tension headache, but that's different. I don't have any vaginal dryness, which is really a huge improvement just in overall the way I feel. I'm not getting up 4 or 5 times at night to urinate. My urinary frequency is gone. My urinary urgency is gone. And patients across the board experience relief in all those symptoms that we talked about. And their relief is much better and sustained for much longer and much more effectively treated with the use of pellets. Now, I will say that a lot of my patients don't want to do pellets. The majority of my patients do. And sometimes, I'll have somebody come in and they'll tell me they're really sensitive to medication and they're afraid to start on pellets. So we'll start something else. My second favorite treatment is to do the troches, because I don't want to give people medication that is bypassing through the liver. I don't want that estradiol being converted into estrone. We know that estrone is not a favorable form of estradiol for hormone replacement therapy. So the creams are probably my second least favorite, because my least favorite obviously is synthetics. My second would be the creams, although I do prescribe a lot of creams. If women want to try the bioidentical creams, well, we can put progesterone, testosterone, and estradiol into those creams. And that's very easy. We can put DHEA into those creams. It's an easy form of treatment. We can put into the troches progesterone, testosterone, and estradiol. So you have all three in one. But overall, the most effective form that I've found thus far to give the best symptom relief, to really regulate and balance out the hormones, has been the BioT pellets. And so they are my personal favorite, and I do recommend those quite frequently, but I'm very pro-patient choice. And I always tell people, I am not trying to sell you the pellets. I want you to be on a form of bioidentical hormone therapy that you want to be on. And some women don't want to be on hormone replacement therapy. They want to know what their hormone levels are, and maybe they're going to try something like dietary changes, which they can try. Sometimes they get some symptom relief, which I think is great. Sometimes they don't. and we go from there. But as far as, telling people, oh, you have to be on this, I am not that type of person. I want people to be on a therapy that they want to be on because it's going to work better for them. I don't ever want anybody to feel pressured that they need to do hormone replacement therapy, but that's usually not the case. I mean, I have women calling because they want hormone replacement therapy. And so we provide, the treatment options, what's available to them, and then they decide. And I do have a lot of women who start on creams or they start on troches and then they want to try the pellets. So what's the downfall to the pellets? Because they sound like they're great and they work fantastic. Why wouldn't everybody do them? Well, they do have a little bit of discomfort because about a 4 millimeter incision is made. What's called a trocar, which basically looks like a metal syringe, is inserted into the subcutaneous fat. The plunger is taken out. The pellets are put in. Plunger is put back in, and the pellets are pushed into the tissue. The trocar is taken out. A steri strip is placed on, and a bandage over that. And they have to do a little bit of activity restrictions, not get into water for about 3 or 4 days. So there's a little bit of recovery time, not substantial. I tell women don't do a lot of gluteal exercise on that side when we put the pellets in, because you don't want the pellets to extrude. There can be some bruising. There can be a little bit of bleeding or oozing. There can be a little bit of discomfort, for which people can take Tylenol for. And we go through all this prior to even putting the pellets in. But the one thing I do tell people is that once the pellets are in, you can't take them out. So I guess the biggest downfall is if you give somebody too large of a dose, they could have side effects that they don't like, which is why when I put the information into the computer to get the recommended dose for the estradiol and the testosterone, sometimes I'll back that down a little bit because I don't want to give somebody a side effect. Once someone has a side effect, especially on an initial treatment, they don't want to do it anymore. And they don't care if it was because the dose is too high. It's like that with almost any medication. So a lot of times I'll start lower and we'll move up a little bit slower. So if somebody, I put them into the computer and it says they need 15 milligrams of estradiol. And I feel like, well, hey, that computer doesn't have breasts. It doesn't have nipples. It isn't aware that they can become swollen and tender, and women don't like that. I might decrease the dose to say 10 milligrams or sometimes maybe even 6 milligrams, depending on how the patient presents and what she tells me her symptoms are. Same with testosterone. I don't want women to have a side effect to the testosterone, which would be increase in oily skin, acne. I don't want them to have hair loss. I don't want them to grow big dark facial hair, and I don't want their voice to become deep. So we don't start people on high doses of testosterone. If I think that the dose is a little bit too high, I might back the dose off a little bit because I can always put in more. You can always put in more hormones with pellets, but you can't take it out. Now, just because you can't take it out, if somebody does have a side effect, a lot of times there are treatment options for those side effects. Like if someone is having breast or nipple tenderness, they can take some evening primrose every night orally, and that decreases that. Or we have testosterone blockers that we can use if we need to. But that's never been a problem at my clinic because we start a little low and we move slow. Now, I will say that the computer usually is pretty accurate on what women need. And so a lot of times I don't back the dose down, but everything is individualized to meet that woman's needs because that's what's important. We are not made out of cookie cutters. We're all individual and we need to be treated like individuals. And that's one reason that I don't like using pills, because if I were to replace somebody's hormone level, even with bioidentical hormones in the form of pills that are FDA approved, I only have several doses that I can use, and then that's it. So I got to pick one of 3. Well, maybe that woman needs something that's a little in between. Well, I can't do that with a pill. I can do it with a cream. I can do it with a troche. I can do it with the pellets. But the pellets, to me, with the most natural absorption through the subcutaneous fat, because they're fat-soluble hormones, makes the most sense to me. So I always tell women, 1, you don't have to do anything. Nobody has to do hormone replacement therapy. That's an individual choice. 2, we give them the treatment options. What do they feel like is going to be the best treatment option for them? And then we do the treatment. And then I always follow up with women. I tell them, everybody gets my home phone number. Everybody knows every way possible to contact me, and they can contact me 24/7 if they're having an issue. I don't want people to wait and get worried. And it's, 8 o'clock at night on a weekend. Well, you know what? Text me. And they can text me with their questions or their concerns, and they're going to get a text right back. And that's how it should be. You don't give women hormone replacement therapy and then just say, okay, bye, we'll see you in a month. They have to have the ability to contact you. But usually I'll do a formal follow-up visit in a month. See how they're doing on their hormones. See how they're feeling on their hormones. A lot of women who are on the creams or on the troches may switch. They may say, okay, let me try from the cream to the troche. Or, hey, let me try going from the troche to the pellets. Usually once women do the pellets, I don't have hardly any women that don't continue the pellets because it is a game changer. And then another question that I get asked, which I forgot to bring up, is, well, how long do you do hormone replacement therapy? That's what they ask me. Well, do I have to do this forever? And I tell them, nope, we only do it as long as you want to feel good. That's why I'm going to die with pellets in me, because I like feeling good. And my mom, who's 84 years old, I pellet her on a regular basis. My daughter gets pelleted, and she's not perimenopausal, but she was feeling bad. She was having fatigue, and her testosterone level was low. So why not pellet her? What are the contraindications to pelleting somebody? Well, if they've had breast cancer, we don't give women with breast cancer or any active cancer hormone replacement therapy. However, if someone's been treated for breast cancer and they've been breast cancer free for a year, then you can treat them with testosterone with anastrozole. So there are pellets that have testosterone and anastrozole in it. The anastrozole is an aromatase inhibitor, which means that it blocks the conversion of testosterone into estrogen. So we know that testosterone is a huge, low testosterone is a huge reason why people start to develop cancers when they're older. So we know that there's a huge correlation between testosterone and breast cancer, colon cancer, heart attack, stroke, having increased risk in Alzheimer's disease, having increased risk in osteoporosis. So if we balance our hormones, then we can help diminish the risk of those illnesses, because it never made sense to me. Why is it that people over the age of 45 start developing all these illnesses? We don't have them when we're younger. You don't normally see people in their 20s walking around with Alzheimer's disease or having heart attacks unless there's a familial predisposition or a congenital problem. But the overall average healthy individual doesn't start having these issues until they're much older. And the key factors with current research that's out seem to be related to the hormone depletion. So our bodies are designed to live to be 45. When we die at 45, it doesn't really matter what our hormone levels are. We haven't even completed, most of us haven't completed menopause. So we don't really feel bad, but we're living into our 70s, our 80s, our 90s, our 100s, and our quality of life is just diminishing because our hormone levels are not balanced. So by balancing our hormones, we can improve our quality of life. We can decrease our risk for a lot of these problems and live longer, healthier, happier, high-quality lives. And that's what I want. And I'm not saying that hormone replacement therapy is for everyone or for anyone for that matter. It's for people who want it, and it's for people who want to look into it. So talk to your healthcare provider who has knowledge in hormone replacement therapy. It's very rare that most providers have substantial training in hormone replacement therapy. Even physicians don't have a substantial amount of treatment in hormone replacement therapy. We're taught in school, so I've been to nurse practitioner school, I've been to nurse midwifery school, and I've completed the didactic of medical school. And so I know what they teach. And they teach what big pharma is dealing out, period. There is not much. Now, in midwifery school, that's not completely true. We did learn about bioidentical hormone replacement therapy, but it was a week of lecture, and it entailed a lot of different things. And so unless you get specialty training, most providers don't know about it. Most providers are scared of it. and they don't want to put themselves or their patients at risk. And I totally understand that. But providers need to look outside the box. If it doesn't make sense, and it doesn't make sense to me that hormones cause cancer, or we'd all have cancer in our 20s and 30s, if it doesn't make sense, then look at it from a different perspective. Think outside the box. Get educated on what bioidentical hormone replacement therapy is. Yes, I think synthetics are dangerous and I don't like to use them, but I think bioidentical hormone replacement therapy for the majority of people is very safe. And I do have women in my practice that have had breast cancer that I treat with testosterone replacement therapy with anastrozole in it to block the conversion to estradiol. And they're living happy, healthy lives. They feel good. And that's the point, right? Why do you want to go through life feeling bad? I mean, I guess if that's something that works for people, then that's fine. I am not of that mindset. I want to feel good. I want a healthy life. I want to be hiking and bungee jumping and skydiving when I'm 100 years old and not have my back strapped to something in a wheelchair or be strapped to somebody else. I want to be independent. I want to live as healthy and as long as possible. And that's why I have this huge passion for hormone replacement therapy and thinking outside the box and not just listening to the complete big pharma telling people what they need to be doing and listening to trials that are not performed well and that we're giving women medication that's not appropriate for women. Women need medication that's natural for them, not some synthetic horse urine that's being put into their systems or a synthetic progesterone. So if you're on hormone replacement therapy, look at what you're taking and see if it looks safe to you. If it's not, talk to somebody. You can look up online for providers for bioidentical hormones, and it doesn't even have to be BioT. BioT happens to be what I like, but there are a number of bioidentical hormone replacement therapy options. And look those up and call the providers and make an appointment if it's something that you're interested in and get actual information. Don't be afraid to do something that has not been proven to be dangerous. You know, it doesn't make sense to me to put fear into people and have them living lives that are of low quality. My whole perspective is to have happy, healthy patients. And I want them to make the choice on what they do. And so I don't push hormone replacement therapy, again, on my patients. If they want it, I want to talk to them about it. I think it's a great idea. But if they don't want anything to do with it and they really are afraid of it, well, number one, they're not going to call my office to get hormone replacement therapy. But if they mention it, you know, in the context of I'm treating them for something else and they happen to see it in the office, I will give them information. In fact, anybody at any given time who wants to come by my office who's in Santa Fe, New Mexico or the surrounding area, you can pick up free books on bioidentical hormone replacement. I have them in my office available every day. All you have to do is come in and ask for them. And you don't even have to make an appointment. You don't even have to be a patient. You can just come in and say, hey, I heard this podcast and I want to get more information, and I'd be glad to share it. And so that's the end of this podcast. I'm going to do a podcast on andropause for men, basically men's menopause and low testosterone levels, and treatment options, again, through bioidentical hormone replacement, as well as synthetic, because a lot of men are familiar with synthetic. Again, I think it's a more dangerous form of treatment. But we're going to be talking about that next week. And just get information. Information is the most important thing because knowledge is power. That was the really big take-home point that I learned in nurse practitioner and nurse midwifery school, is that knowledge is power. And that's why it's so important for women to empower ourselves. And how do we do that? With knowledge throughout anything in our lives, not just hormone replacement therapy, but anything. If it doesn't make sense to you, it probably doesn't make sense. And so look for the answers. Look for what makes sense to you. Don't just believe what anybody's telling you. Don't even believe what I'm telling you. Look it up and see if it makes sense. Because if it does, then you should be doing it. And if it doesn't, then you shouldn't. And don't believe what you read in the media. Don't believe what you hear on TV if it doesn't make sense to you. If it makes sense to you, then that's fantastic. Then go with it. But if it doesn't, educate yourself and educate yourself on research that's available. If you want more information on research that you can look up that's out there on bioidentical hormone replacement therapy, look up Gary Donovitz, Donovitz. He is the founder of BioT, and he is doing a lot of research on hormone replacement and the benefits and seeing if it makes sense. And in a lot of areas it does. He's seeing a huge improvement in osteoporosis in women with testosterone, and they are looking at tens of thousands of women, not just a study with 100 women or 50 women or 25 women. This is thousands of women that are in these studies, and it's important. And he has been a game changer for women. So look him up if you want to see the research, and look up providers that do bioidentical hormone replacement in your area. You can also go to our website at www.evercarefamilypractice.com. You can contact us on our website. You can contact us on Facebook, on Instagram. You can contact us by calling our office at 505-780-8301. And I would welcome any questions or comments. And I know that hormone replacement therapy is a heated topic. And I would say that if you have questions or you have comments, I would love to hear them. And I will be glad to answer anything that I can. If I can't answer it, I will find an answer for you. And I am not afraid to tell you, hey, I don't have an answer for that, but I'll get you one. And so, be an informed consumer. See what works well for you. And then live your life happy and healthy and individually. And I encourage everybody, and I wish everybody a healthy, happy life, and in making the health decisions that are best for you, and in living your life with freedom to make your own choices, not only with your health care, but in everything you decide to do in life. And I appreciate you joining us for this podcast today. I want to thank everyone who joins us from New Mexico, Pennsylvania, California, India, throughout the United States. I am just thrilled to be able to provide information on healthcare. It is my passion in life. It is what I live for. It is what I love to do. And I want to thank Brad F., Kathy V. I want to thank Andre. I want to thank Samantha, all of our listeners for their support and taking time to listen to us during your busy schedule. And have a great evening. Thank you.